So on behalf of everyone here at PHI, I'd like to welcome you to PHI's January Town Halls. So this is the first offering in our 2023 educational program. We're so happy that all of you could join us for today's session, which will be on post-polio bracing with our special guest host, Dr. Marny Eulberg. Dr. Eulberg is a family physician, longtime member of PHI's board of directors and the chairperson for Rotary District 5450's Polio Committee. And she is herself a polio survivor. She's written numerous articles and spoken to many post-polio organizations. So a lot of you might already be familiar with Dr. Eulberg and her work. And we very much appreciate her taking the time today to talk to us about bracing as it relates to the late effects of polio. Just before we get started, a couple of quick notes. So Dr. Eulberg will begin here in just a minute with sort of a short lecture going over the basics of post-polio bracing. And after she finishes, then we'll open it up for questions. The process for submitting a question is, you'll see at the bottom of your screen, there's a Q&A button. So just click on that, enter in your question, type in your question, then it'll send it to us and we'll pass those along to Dr. Eulberg. And then just finally, before we get started here, I'd like to thank the Christopher and Dana Reeve Foundation for their generous sponsorship of our town hall and lecture series for this year. If you'd like to support PHI and programs like this that we're bringing you today, you can go to PHI's website, which is www.post-polio.org. And there's a donate button right at the top right-hand portion of the screen. I'll also post a direct link in the chat feature too here in a minute. So well, without further ado, I will turn it over to today's speaker, Dr. Marny Eulberg.
Thank you. Good morning to those of you who it's morning, and for the eastern half of the United States, I know it's afternoon. I anticipate that those of you that are attending will have a wide range of knowledge about bracing. Some of my words here are going to be pretty basic, but I think it's important that we all are using similar language as we talk. I'll be talking almost exclusively about leg bracing, but bracing for the back or sometimes the shoulder or wrist may also be useful for polio survivors, but it's just much less common. So years ago, I heard Dr. Jacqueline Perry talk about the ideal brace, and this concept is just always stuck in my head. She talked about the first 4 things on my list. I added the 5th, but so the ideal brace does what it needs to do in terms of supports a drop foot, supports an unstable knee. It weighs nothing. It's invisible, or at least cosmetically appealing, costs nothing, and is comfortable to wear and easy to put on or off. Orthotists will say donning, meaning putting on, and doffing, D-O-F-F-I-N-G, which is taking off. I have to disclose that there's no brace that meets all of these criteria yet, and probably never will, but we're moving closer. Braces can weigh less now than they did when they were made of stainless steel. Some of them are a little more cosmetically acceptable. And they should be reasonably comfortable to wear and easy to put, relatively easy to put on and off. My agenda is to talk about first, which medical specialty is expert in bracing, what kind of braces exist, so some vocabulary, what kind of brace you might need, and how do you find an orthotist. So in terms of which medical specialty owns bracing, certainly for me, as I was growing up, probably for many of you too, it was the orthopedic surgeon, the orthopedist, who prescribed the bracing and recommended the bracing. That is really no longer true. In orthopedic residencies, they get about 1 hour of lecture about bracing and 1 hour about artificial limbs. The specialty who gets the most significant training about evaluating and prescribing bracing is physical medicine and rehabilitation, or also known as physiatry, or some people pronounce it physiatry. The two pictures to the side are just screenshots I took of their websites. At the top, the American Academy of Orthopedic Surgery, and at the bottom, the American Academy of Physical Medicine and Rehabilitation. So what about neurologists? And what about PTs? So I've talked to a number of physical therapists and a few neurologists. Bracing is not part of their routine training, but they may be self-taught. This creates a problem because the orthotists need healthcare providers to provide detailed prescriptions and documentation of the musculoskeletal exam and the need for the brace in order for them to get paid. I'm not going to offer any big solutions for how to bridge that gap. The orthotists have learned that in order for them to get paid, they may need to provide some suggested language for the prescribing physician to use. Moving into vocabulary so that you speak a little more like a professional and that we also are talking about similar things. The current vocabulary is to include the letter O for orthosis, which orthosis is the new word for brace or support. And the name includes what part of the body the orthosis fits on. So a foot orthosis, or sometimes just called orthotics, is FO, and there's a picture here. AFOs, ankle foot orthosis, can be in a number of designs, and I've shown 3 examples here. It can be metal and leather and plastic. It can be carbon fiber off the shelf, as in the middle, or it can be various plastics, polypropylene on the right. And this just, the brace crosses the ankle. So it goes generally under the foot and crosses the ankle, going usually up to at least mid-calf and to just below the knee. A KO, or a knee orthosis, can be custom made or it can be off the shelf. For most polio survivors, it needs to be custom made in order to fit both the thigh and the calf, because our thighs and our calves don't follow necessarily normal contours. A number of polio survivors who have reasonable strength in their foot and ankle, but more weakness around their knee, have asked and would like to have just a knee orthosis rather than a brace that goes all the way down into their shoe and their foot. However, if you have a really small calf a KO will frequently not work very well because they're designed to sit on the roundness of the calf muscle, almost like a shelf. And if that shelf's not there, the brace will frequently slide out of position and may slide down even all the way to your ankle. So there needs to be a way to, if someone has a weak calf, a small calf, to either keep the brace, hold the brace up from the top, or hold it up from the bottom. Then a knee, ankle, foot orthosis, or what in bygone days was called a long leg brace, now a KAFO. The ankle can either be solid or have a joint. And the knee can either be free, which allows movement, flexion and extension, or it can be lockable, or it can, and the lockable usually has various designs that allow it to automatically lock when the leg is straight, but then it needs to be unlocked in some way when a person wants to sit down or bend the knee. What kind of brace might you need? Generally, it's going to be better if it's custom made just for you in terms of fitting better. It also, insurance will pay for a custom made brace, although they like to pay for off the shelf because they're cheaper. But the criteria usually for a custom made is that there isn't an off the shelf version that would work for you, that the person needs the brace for at least 6 months or more, and that the body that it's going to be braced, it has some unusual contours, either because of deformity or because of atrophy. There are computerized electronic braces. This is a picture of one that's called a C brace made by Ottobock. They're still developing these, and as computers and batteries get smaller, I expect that they will weigh less and probably be less expensive. But at the moment, they're the part that supplies the motor and the computer interface weighs about 3 to 4 pounds. And my understanding is that the price range is somewhere in the range of $50,000 for a single leg brace. And most insurances will not pay for it or only pay a small portion. So what conditions can an AFO help with? The primary condition that an AFO helps with is either foot drop, and the picture on the left shows in this person's right foot is in a drop position because as the weight is coming off the left foot, the heel should be down on the right foot to accept the weight. And this person is toe first instead of heel first. Also, for the ankle turning in or out, which is medically termed valgus or varus, and the pictures are there. Valgus means that the part, in this case, the heel, goes away from the midline. And varus means the heel goes toward the midline. An AFO can also help with mild knee weakness by providing some support up through the calf. But if your knee is buckling when you're walking, an AFO is not going to provide, generally not going to provide adequate control. An AFO can help with a weak knee if it utilizes what we call ground reaction forces. And in that case, the ankle motion needs to be limited and perhaps not allowed at all, be a solid ankle. And there needs to be some kind of firm support in front of the knee below the kneecap. And there are pictures here showing a couple different designs. So when is a KFO usually needed? This is usually needed in people with a weak thigh, loose knee ligaments, and deformities. On the left is a picture showing sort of the normal alignment of the thigh bone and the lower leg bones. The middle is varus, which is commonly referred to as bow-legged, and on the right is valgus, which is knock-knee. Again, the lower part of the leg is going away from the center, from the midline. Picture on the right, it just shows significant hyperextension, and this is a frequent reason that a KFO is needed. And usually recurvatum, or hyperextension of the knee, happens because of weakness of the muscles on the front of the thigh, the quadriceps. There are some situations that make it very difficult to successfully brace, and those are a severe fixed deformity anywhere in the leg. And fixed means that it's solid, that it can't be moved, that the orthotist or the physician, as they put their hand on your foot and ankle, can't move it through, at least partially through its range of motion. If people have greater than about 15 degrees of a knee flexion contracture, which means you can't straighten the knee all the way out, it's hard to brace that because it's just very hard to walk with a bent knee. It may be difficult to brace someone if they have severe weakness of the muscles of their hips, particularly the one that bends your knee, brings your knee up towards your chest, because those are the muscles that are used to advance the leg forward to take the next step. And all braces have some weight, some of them more than others. And if even without any brace, you have difficulty stepping forward, moving that leg forward, you're going to have difficulty with the brace, with the added weight of the brace. I have had people tell me that they search high and low for shoes that weigh virtually nothing, because any shoe with any weight is just too much for them. They're tripping over it and it's too much for them to lift. They may not be a candidate for a brace. And then finally, leg swelling that fluctuates over the day. The brace ideally should fit fairly close to the skin, and fairly snugly, but not too tight. And if your leg swells a great deal as it goes through the course of the day, the brace that fit in the morning is not going to fit at the end of the day. I did about 7 years ago form a nonprofit called the Human Gait Institute, and this is composed of volunteers who actually all are polio survivors, and all are brace users, to try to help people understand what they might need, what the resources are, particularly as they look for maybe a better brace, or if they're experiencing the need for a brace for the first time. On the right is a screenshot of the homepage, and on below, we created a several-page workbook that asks a series of questions and lets you go through the process and come to a flow chart that would indicate what types of braces might work best for you and what kind of questions to ask. There's a difference between needing a brace for the right leg and the left leg, particularly if you're still driving. If you're still driving, you need to be able to have the ankle bend enough that you can depress the accelerator, or have enough strength around your hip that you can use your whole leg to push on the accelerator. And so for you, brace on the right leg with a solid ankle may not be something that you're willing to deal with. The website is listed there, www.humangateinstitute.org. And if you look under ideal brace, and scroll down a bit, you'll come to the workbook that you can either access and go through online, or it is in a PDF that you can print out and go through the questions that way, or give to someone else who doesn't have computer access or skills. A number of polio survivors are not aware of the term orthotist. When I was growing up, it was Mr. Erickson, the brace man. But they are now called orthotists. And the educational entry level for orthotists is now a master's degree. As you begin to try to find an orthotist, you'll need to consult with your insurance, especially if you have an Advantage Medicare plan, an HMO, or a PPO, because they'll have some limited choices that you can choose from, and that they will still help pay for the brace. On the right is a screenshot of one of the accrediting agencies, the American Board of Certification in Orthotics, Prosthetics, and Pedorthics, usually called ABC. And as you can see, that's in the website, www.abcop, so O for orthotics, P for prosthetics.org. And as you scroll down, you can search the directory and find a certified individual or a certified facility that is, and you can put in parameters so that it's within 50 miles of where you live, or 100 miles of where you live, etc. There is another national credentialing organization, which is the BOC, or Board of Certification and Accreditation. And their website is there, www.bocusa.org. They also have a directory, and I've circled it in red in the screenshot from their website. Terminology might be a little confusing. It's certificate directory. Knowing about the credentialing organizations for orthotists and prosthetists is useful and important, because some states have a state licensure process for orthotists and prosthetists, but some, such as here in Colorado, do not. So anybody with some mechanical skills and an interest could set up practice as an orthotist, as long as they could find physicians to refer to them and insurances that would pay for that. So I think it's useful to know what the national accrediting organizations are. That doesn't mean that the person is going to be somebody that works well for you. There's always personalities involved, but it gives you some basic qualifications. There are people who are excellent orthotists who have not done this accreditation, not attended the official training programs, who just have a knack for such things. But I think it's useful to know that people have at least some basic qualifications. we'll move to some of the questions. Some of you I see have already submitted some. I will caution you that if you're trying to ask me what's the best brace for my particular situation, in this forum, I cannot see you. And when I see someone for a brace evaluation, I usually spend an hour and a half to 2 hours. It's really useful to have my hands on the person's limb to test their muscle strength, to look for range of motion of joints, and to then talk with them about what their desires are of what the brace might or might not do, and then for them to have an understanding of also what it will not do or how it might limit them. So I will. Okay, so some of the questions.
Yeah, I just want to thank you again, Marny, and remind everyone, if you have a question to submit, just click that Q&A button at the bottom of the screen and type it in, and we'll try to get to it.
Okay.
Yep.
So first question I see is, have you found any problems with Medicare funding both leg bracing and also a power wheelchair that requires that you cannot ambulate? Occasionally, but the issue is Medicare doesn't require that you can't ambulate. It's that you can't ambulate enough to do the mobility related activities of daily living in your home. One of the ways to still convince Medicare to pay for leg bracing and the power wheelchair is that the person needs the bracing to transfer, to do a standing transfer. And, you know, it's always a bit of a challenge with Medicare, what silliness they're going to do or not, but adequate documentation by the orthotist and the prescribing physician should be able to work around that. A question also, how does one manage hyperextension when one can't support one's weight if the knee is locked? There are basically two types of knee joints in a brace. One is what's called an offset, or a and that limits how far one can hyperextend. There also are some ways with straps and that you can limit the hyperextension but still allow some hyperextension. And there are ways of locking the knee. It doesn't have to be totally at 180 degrees or straight out. It can be locked with the knee partially bent, but there's a limit to how far that can go. Other question, please talk about crutches. I use a stance-controlled KFO, which works reasonably well, but I've had a lot of arm problems, presumably related to overuse of my arms. Yes. Our creator did not design arms and particularly shoulders to be used to walk on. And so the people who have done weight bearing through their arms with either with crutches or propelling a manual wheelchair over the years do tend to have problems related to overuse of their arms with some tendonitis or arthritis. And that's a challenge. Ideally with a KFO, some people can do okay with a KFO and not need to use a cane, walker, or crutches, but most people do better with some kind of upper extremity mobility aid to just at least help with balance. Question, my doctor says I should not have a brace because it will make my leg weaker. Piriformis has atrophied in pelvis muscles. Is there a brace just for the hip and thigh? Okay, first of all, a brace may, because it will have some of the muscles not need to be used as much, or it may make the legs slightly weaker. Although if you, for most of us, if you're still able to walk some without your brace, you probably do that some of the hours of the day, particularly like when you get up at night to go to the bathroom. So you're still using those muscles some, and generally a brace is not going to make the leg significantly weaker. If you really need a brace, it's already weak enough that, and stability, and particularly as we age, preventing falls is far more important than keeping your leg from getting weaker. There have been developed some braces for the hip and thigh, but they're generally not very successful because it's very hard to fit a brace that will work and provide you support when you're standing and walking, but is still comfortable when you're sitting. So some of us had braces when we first had polio that was an HKAFO, so hip, knee, ankle, foot orthosis, and some even with a pelvic band that went around the waist. Most of those have been eliminated because they generally are more trouble and more uncomfortable than they're worth. Next question. My brace usually does not last 5 years. I'm active and usually at the end of 4, it is dangerous. I wear a KFO. Have you had any luck getting a replacement in less than 5 years? Did not have a problem getting a replacement until I went on Medicare. Yeah, that's a problem. So some of the things are certainly talking with the orthotist and see if there are ways to make the brace sturdier or stronger materials that may last longer. Unfortunately, insurances, including Medicare, sort of assume that if you're wearing a brace that you're not very active. And that's not necessarily true for many of us. I would emphasize to people that if at all possible, if you really are depending on a brace, that you try to figure out a way to have a backup brace. For example, even if it's not perfect, but would still let you get around. So sometimes just repairing the old brace enough that it could be a backup for at least a week or two for when your current brace is needing repairs. I recently broke the upright on my KFO and was shocked and surprised when I took it into the orthotist and they said, oh, we'll have to order parts. Fortunately, they were able to get the parts within about 4 or 5 days, but in the meantime, I was in a real panic of what am I going to do? And again, documentation from your physician and the orthotist. Usually they will pay, Medicare will pay for repairs. They may not pay for totally replacing it, but they usually will pay for repairs. Another option, if they don't, is talking with the orthotist. Many of them will, if you're self-pay for part of the repairs will give you the rate that they normally would get from Medicaid, which is less than they get from most insurances, and try to give you some kind of deal, particularly if there's if you work with them for a while. Are there a few core questions one should consider including when searching for an orthotist or talking to a provider about finding one? Okay, well, first of all, primary care physicians are probably going to be no better than you in terms of language, and they may not even know what an orthotist is. They, with each insurance, will probably have a directory that they can use, but they may or may not have had any experience with their patients using that particular provider. It's useful, it may be useful for you to talk, like through a polio support group, talk to other polio survivors about if there's a particular orthotist or group of orthotists that they've been pleased with. It is okay to interview orthotists and see if their values sort of align with your values. It's useful to know that orthotists get paid only for the product they sell. So just like a pharmacist, the pharmacist gets paid for the medication they dispense to you, but they do not get paid for their expertise in looking at drug interactions or side effects or counseling you about the use of the medication. Likewise, orthotists cannot bill and do not, well, they could bill you privately, I mean, on a self-pay basis, but insurances will not pay for their time for an evaluation or education, which I think is awful, but that's the way it is. So it is worth knowing that there are some orthotic companies that have a quota of how much product their orthotists, their practitioners need to sell or have go out the door each month. If you are fitted with a brace and when you go in to pick it up, it does not fit or does not work the way you want it to, it is better to not leave with it, because if you sign the paper that you've taken possession of it and walk out the door, then you're unlikely to be able to get any refund or to return it. Another question, as we age and change shape, should we get new braces to adjust to us? Yes. The comment, this would be especially for back braces. Yes. So many of us, I think, get a brace and sort of expect it to last forever and meet our needs forever. Our needs are going to change. Our bodies are going to change. You may have, for example, had a fracture of your back or of your leg, and now the shape changes. And that can mean that you need a new and different brace, and that may need to be documented of why in less than 5 years, you now are needing a whole new KFO or a whole new TLSO. Let me also just say, I didn't include in the vocabulary, but TLSO is a back brace, thoracic, lumbar, sacral orthosis. Question, can an AF, so I assume ankle foot brace, help my balance problems? Possibly. Depends on sort of what's causing the balance problems, but it can provide better foot support and better foot position so that your foot is flat on the ground and in contact with the ground, rather than, for example, being most of your weight on the outside of your foot and you're walking almost like on a ice skate blade. It can also, for some people with some peripheral neuropathy, which is not part of polio, but can be coexisting. If you don't have good feeling in your feet and ankles, sometimes an AFO with the top portion of the brace up near your knee, where you get where you do have feeling, can transfer some of that sense of force from the ground higher up in your leg where you do have normal feeling and give you better balance. Okay, I got an off-the-shelf KO 6 months ago. It's inadequate. I'm now in process of getting a custom brace. Is there a way to get Medicare to pay for this brace? Yes. It should, with appropriate documentation from the orthotist and from your physician about why the off-the-shelf KO is not working, and justifying the need for a custom brace. Medicare should pay for it. It may take some haggling, and there is an appeal process, and that can happen. Next question I see is, how does one manage hyperextension when one can't support one's weight if the knee is locked? I answered that already. Okay, will my varus get worse if I only wear my brace 4 hours, 5 days a week? It may. So if the varus or the valgus is, if you're not wearing the brace and you're standing or walking without the brace, then the force through the leg is going to be, when it's already bent a little bit, and now the weight of your body through your leg down to your foot, the force is going to make that bend more, whether that's this way or that way. And a little bit of varus or valgus, that the forces are not such that it makes it too much worse, but beyond, at a certain point, it just gets worse. Just imagine if you had a metal pole that was slightly flexible, and if it's starting to bend, and now you put weight from the top of the pole down to the bottom, the bend's going to get greater and greater. And part of the bend is because the ligaments on the inside or the outside of the knee have gotten stretched. And if the forces are such that it stretches them more, it will just keep stretching that. Just like most of us probably started off with a little bit of hyperextension, and over time, the knee went back further and further, and we stretched out those ligaments more and more. Okay, question. As a teenager, my brace man always talked about alignment. He made the best braces I've had in 70 years experience. Do you know what he meant by alignment? Yes. Alignment is trying to get all of the bones in the leg, in that part of the body, whatever, to line up as near to normal as possible. And that can be, you know, from the top to the bottom. It can be side to side, or it can be rotational. One of the orthotists that I've worked with a lot in the past, his primary purpose is starting off is to get as near to normal alignment as possible. Okay, question. Are there types of brace parts, joints, etc., that are harder to find? Why does it take so long to get? It took me 4 to 6 months to get my last braces. So as with a lot of other things, particularly during the pandemic, there were supply chain issues, and there were some parts that were harder to get than others. Also, there are some parts of the braces that we wear as polio braces that are not used much in braces for other conditions. For example, someone who's had and so it's less and less profitable for companies to make those particular parts. There, I would suggest, so there are orthotic companies who just have very basic supplies in their particular office, and they send most of the stuff out for fabrication to someone else. There are others that that do most of the fabrication in their office. If so, they're going to have more of the parts, and they also will have a much quicker turnaround time and are more likely to have it work well for you, because the person doing the fabrication or very involved in the fabrication is also the person who had their hands on your leg and on your body and knows what to do. The person who's receiving the cast or whatever miles away and has never seen you, never met you, is going to have a harder time doing some fine adjustments. Hey, question. Where can I find springs that hold up long leg brace, the ones they supply now, either crush or break? I never had this problem several years ago. Again, this is a challenge that a lot of the more common braces these days don't have springs in them. I did wear an AFO that had springs in both the front and the back of the ankle joint. So I had 4 springs, and I broke about a spring a week. It took me a very long time to convince the orthotist to just give me some springs, let me fix it myself, because I was working, Monday through Friday, 9 to 5 or 7 a.m. to 7 p.m. And could not go into the office once a week when a spring broke to get a new spring. I do still have a few springs left from that. But I think it's also worth really pushing your orthotist about, are there better springs? And I'm sure there are some that are made for, that might work, that are made for other kinds of devices. Question, will bracing in the future ever utilize 3D printing? Is anyone looking at this now? Yes. So it's has been looked at most in prosthetics. And I think, maybe some of you have heard of a junior high or high school class that created, with 3D printing, created a prosthesis for an amputee. It is that and CAD camera, 3-dimensional looking at things has been used particularly for the stumps of an amputee. The challenge is that it really is useful. The CAD does not tell you, it tells you the contour, but it doesn't tell you whether the tissue under that is hard like bone or whether it's soft tissue and could be pushed on, and how much pressure it might take. So there is some things to be done with that. What the advances in bracing and orthotics seem to come after they've been developed for prosthetics, and some of that is that payment for prosthesis is much better than payment for orthotics, so it spurs more innovation. But yes, the other question will be with 3D printing is what the materials that are used for the 3D printing, whether they're strong enough to support a person's body weight, and or how much flexibility they would allow, and if you can control that. But yes, there are folks looking into that. And like I said, mostly for prosthetics. I'm not seeing, oh, I need a sacral lumbar corset. I always got it through OOP Lab here in St. Louis. Now they say Medicare wants competitive bidding. Have you heard of this? Yes. So Medicare, you know, as you all have heard, you know, faces some financial challenges. And they're looking for ways to provide care for their recipients, but at a reasonable price and sometimes the cheapest price. Competitive bidding does require that they look at 2 or 3 suppliers of the product, and also that the people who are billing Medicare have gotten some certification. Not all orthotists choose to do that, just like not all wheelchair suppliers choose to go through the process to become a Medicare certified provider. And that can mean that you have less choices, but your O&P, the person who supplied your corset in the past, should be able to find some other sources if possible. Moving on to the next question. I have drop foot and have tried the ones similar to what you've pictured. They are terrible. I went to a podiatrist and finally found wonderful help with an SA-EBO brace. After the orthotist tried this, it's lightweight, easy on and off, and most importantly, it works. The perfect brace you mentioned initially. It's a brace often used for stroke patients. I lock my knee to walk and do not use brace currently on the knee. That's great. And there are, you know, we all have different bodies and different needs. I'm not familiar with the SA-EBO brace, but I will look at that. It does pay to keep looking, and it's amazing if you go online and look. You can buy all kinds of braces online, but most of those are not going to work for many polio survivors because they're designed for a person to have a proportionally same size thigh and calf, or the size of a thigh and the size of their calf that would fit with most normal people. And you know, sometimes I had one patient who bought a polypropylene AFO at a yard sale for $1.50. That actually worked pretty well for him, but I certainly would not recommend that you go out and buy your braces at yard sales. Next question. I don't use a brace right now, but I fell recently. Is this a sign I need a brace? Well, it depends on what caused the fall. If you slipped on ice, probably a brace is not going to keep you from slipping on ice or a patch of, you know, a wet floor. If the reason you fell is that you tripped over your toe because you have foot drop, then a brace might be helpful. Or if your knee buckled and just went out from under you, then it also might be a reason you need a brace. Okay. Next question, will there ever be a heating component to any form of bracing? In parentheses, space age level, I know, but as the impact of coldness on mobility is real, it's worth pushing the orthotics professionals in assessing the possibilities. I don't know why not, but the challenge would be providing the source of the heat. Probably would have to be like the heated socks or the heated mittens, some kind of battery pack. And again, that's going to be some weight, going to require some recharging, etc. But I don't know why not. Next question, please talk about ground reaction braces. I normally use a stance controlled KFO and had a doctor recommend an AFO ground reaction brace. After months of trying, it didn't work. When is a ground reaction brace a win? So ground reaction basically so it requires a limited motion or no motion in the ankle so that as the weight goes forward on the foot, there are forces against the front of the knee to keep it from buckling. And it's going to work for different people. It requires some certain requirements, like in order for it to work, the person needs to be able to get their knee nearly completely straight. It would not work for somebody who has a knee flexion contracture. And it also requires that you don't have too much hip flexor tightness so that you can get your hip in front of your knee to really have that control. I have seen it work work well for some people. And in fact, the time that I really encourage people to think about a ground reaction AFO is for certain people who've used a lock knee KFO all their life, because being able to have a free knee is a real advantage. But it requires very careful evaluation by the orthotist and you, and perhaps even some way of sort of trying it in advance. Do I have any comment about back bracing? Sure. So back bracing, if people have weakness of their back muscles or weakness of their abdominal muscles, can be, and you're sort of a jellyfish in the middle. Back bracing to provide some support can let you use your arms more effectively, perhaps let you walk where you might not have otherwise been able to. But it's a challenge, because to provide enough support in that situation, then it's going to be hard and firm and going to like really limit your ability to bend over sideways and pick things up from the floor. It's also really difficult to have a back brace be in the right position when you're standing or walking, and then not right up when you're sitting. So it can be useful, but it definitely, like anything, it also has some downsides. Do I have any info on human growth hormone and its impact on leg strength? All of the research that I've seen on human growth hormone, on all the other medications that were thought to hold promise for helping with muscle strength or any of the problems with post-polio syndrome, have not in double-blind studies been shown to be effective. And so the other question was possible negative impacts. I'm not familiar enough with it to know the negative impacts, but any medication has negative impacts. The other concern is that there's a lot of human growth hormone and similar things that are available on the internet, are not FDA approved, are not really tested for purity. And so be a challenge. As far as I know, human growth hormone medically is only indicated for use in children with short stature to try to get them to be a more normal height.
All right, well, I think we've covered just about all the questions that we've submitted. I want to give anyone who maybe wasn't able to get their question into the Q&A feature, if you want to use the raise hand feature right now, it can allow you to ask it live. Give people a minute maybe to chime in there. All right, it looks like we might have one. All right, it looks like it's Elizabeth Peterson. Go ahead, Elizabeth. I think you're still muted.
In the old days, we used to wear a brace that was fitted to the outside of our shoe. Are those still used? And if not, why not? Thank you.
Okay, yes, there are still a few that are fitted to the shoe. Most now have a foot plate that goes inside the shoe. And there's some advantages to that in terms of being able to wear more normal shoes. The other, with the brace fitted on the outside of the shoe, frequently it was a leather shoe with a metal shank through the arch, and not many shoes like that are being manufactured anymore. They can do it into some, sneakers and other more typical shoes. But I did not too long ago have a patient who wore like a child size 4 on her polio affected leg and had a brace that fit on the outside of the shoe, but they no longer made any leather shoes with metal shanks in that size for her. So we did switch to a foot plate that went into a shoe. One of the times that a brace with the metal uprights coming down into the shoe is useful is if people do get a lot of swelling by the end of the day, because then there's room for the leg and ankle to swell. Where in a plastic brace that's fit to the leg and confining, there's not room to swell.
All right, last chance. Any additional questions? Oh, looks like we got one. Well, Louise. I think she's trying to unmute. Give her maybe a second here.
I'll just also mention that if questions come up later, feel free to funnel them through Brian and he can get them to me.
Yeah, we also had a couple questions asking about if the slides would be available or if the talk would be available later on. So I'm just want to let everyone know we will be posting this webinar to the website, which is again www.post-polio.org, and we will be posting it on our Facebook page as well. Well, I think Louise is having trouble unmuting.
I did unmute.
Oh, there we go.
There you
Okay,
go.
great.
My
Go ahead.
My
Mhm.
question, can a long-term severe misalignment of the knee stretch ligaments with a brace?
Depends on the brace, but most braces are designed to limit the stretch on the ligaments in around particularly a knee. But it really depends on how the brace is designed and how much it limits any movement, either front to back or side to side.
It's side to side.
Okay, yeah, that's where it usually is. And in theory, sometimes so side to side is generally the lateral collateral or the medial collateral ligaments of the knee, which are the ones on the outside or the inside. Medial, inside, lateral, outside. There are times that the ligaments can tighten, if they're supported and they're not being constantly stretched, can tighten up a little bit, but usually not enough to then eliminate the need for the brace.
Especially for an 86-year-old.
Yeah, and how many years that it's been stretched, you know, if it's been 15 years, it's been stretched.
The knee probably about 4.
Okay, yep, but probably then, if there's any chance, it's going to take at least 4 years for it to sort of repair itself.
Okay. That gives me a different perspective. Thank you.
Sure. Brian, I think you're muted. I'm not hearing you.
But thanks, Marny. There was a Mary that had her hand raised and it went down. I don't know if she's having technical problems or she just, her question's been addressed through other comments. Oh, we got one through the Q&A. Hold on. Marty, did you see that written question come through?
Okay, so am I supposed to worry about weakness? I bought one of those metal braces, wore it 2 weeks and recognized it was weakening my foot. I stopped using it. Which is better, exercise or brace? Well, if exercise can help, that's great, and that's probably better. Certainly costs less and doesn't have any of the disadvantages of a brace. If on the other hand, that is not working, and particularly if you're falling, then some kind of external support is probably better. Occasionally, some surgery can be useful. It's just a matter of, do you want to provide support externally or internally? For most of us, since we are over 65, we start getting to be higher and higher surgical risks. And as one of the orthotists I know said to a patient, I can provide, in this case, I can provide support to your ankle, but then you can take it off at night. If a brace doesn't work, you're only out the money. I mean, which can be significant, but if the surgery doesn't work, then you're in sort of a world of hurt. But less is always better if it works.
All right. Well, with that, I think we have addressed most of the questions that have been submitted. So I think we will go ahead and wrap it up today. I want to thank once again Dr. Eulberg for sharing her time and knowledge with us today, and also thank all of our attendees for your very thoughtful questions. We will be sending out a follow-up email within the next day or two with a short post-session survey. Thank you to everyone who completed the previous survey. It was very helpful and participation was really good, so we thank you for that. This one again should also only take a couple of minutes to complete.
Brian, do you know what the next town hall is going to be about and when?
We will send out an email announcement later this week with the topic and date and time for that as well. Again, we just remind you to sign up early because demand is really high and we have limited space for these talks, but keep an eye on your email for an announcement for that as well. Thanks. All right, and Marny, any parting comments?
Nope, just things have improved from the bracing of our childhood, but none of them have met all the criteria of being the ideal brace yet.
All right. Well, thanks again, everyone, and enjoy your rest of your day. Thank you.